right, let's look at chapter 1 then. We're going to do an introduction to spirometry and specifically to pediatric spirometry. So in this chapter, what we're going to learn about is pulmonary function testing, where spirometry fits in as one of the pulmonary function tests. We're going to look at the spirometer, how to perform a spirometry test, measurements of spirometry, flow volume and volume time graphs, spirometry results, a brief history about spirometry and the spirometer. We're going to look at the significance of spirometry, the importance of accuracy and precision in data. That's the key to spirometry. We're going to look at the limitations of spirometry, possible complications and risks, people involved in testing and their roles. We're going to look specifically then at spirometry in children and guidance documents for spirometry. So let us get started. So what is pulmonary function testing? Pulmonary function testing are a group of tests that measure breathing. They measure how well the lungs are functioning. There are different types of pulmonary function tests that can be done, and spirometry is one type of pulmonary function test. So what is spirometry? Spirometry is derived from Latin words, spiro meaning to breathe and meter meaning to measure. So essentially spirometry means the measurement of breath. And spirometry is the medical name for this simple, most effective, least expensive test of lung function. And what we know is that some respiratory diseases slow the speed of expired air, and others reduce the volume of air that can be inspired and then exhaled. So to detect these impairments, spirometry measures two things. It measures how much, that is the volume, of air is expired and how fast the air is moving. That's airflow. So spirometry measures volume and flow over a period of time. A spirometer is a testing device which is used to measure the spirometry test. And all spirometers need to meet specific requirements that are recommended for spirometers. So they need to have minimal technical requirements for us to be able to derive all the measurements that we want and to be able to fully understand the test properly. So a spirometer has a computerized sensor, which is part of the spirometer, and this sensor will calculate graphs and results. And these results will then demonstrate a person's expired volumes and airflow rates. And there are different types of technology in spirometers, and each one works on a slightly different operating and measuring principle. But at the end, they all measure, as I said, volume and flow of air over a period of time. So what you're seeing in this diagram is, in figure 1.1, is a variety of spirometers. So you can see that spirometers come in different shapes and sizes. Some are standalone, which means that they have a printing facility in the spirometer itself, and others connect to a laptop through a USB device. All of the software is slightly different, but as I say, there are minimum requirements for all spirometers in terms of the hardware and the software, so that we know that we're measuring volume and airflow correctly. So how to perform a spirometry test? To perform a spirometry, the subject takes a maximal deep breath in to total lung capacity and then blasts the air out as fast and hard as they can into a mouthpiece attached to a spirometer until the lungs are absolutely empty. The test is repeated several times until there are 3 identical efforts which ensure that the results are accurate. The test is often repeated after giving a short-acting bronchodilator to find out how the airways respond to that type of medication, and this is called a bronchodilator responsiveness test. Measurements of spirometry for everyone are compared against people of the same gender, height, and ethnic group and age to detect normality. So, i.e., whether the measured volume and the flow rates are significantly smaller or slower than expected. The 3 key measurements of spirometry are the forced vital capacity, and the forced vital capacity measures how much air can be forcibly exhaled from a maximal inspiration to a maximal expiration. The FEV1, which is your forced expiratory volume in the first second, measures the volume of air measured in the first second of a forced vital capacity maneuver. And then we have the ratio of the FEV1 to the FVC. So that is how much air was blown out in the first second as a ratio of what was blown out in the total blow. And I'm going to tell you a little bit more about these three measurements later on in the training. Now, what is important is looking at the graphs of spirometry. These are the pictures of spirometry, the visual images, which illustrate exactly what is being measured. So if you look at the graph on the left-hand side, that is the flow volume graph, and everything in spirometry is self-explanatory. So if the graph says flow volume, that's because the graph is showing us on the y-axis flow and on the x-axis volume. And in the same way, we are looking on the right-hand side. If you look at the right-hand graph, we are measuring volume over time. So essentially, there's three things that we need to look at in spirometry. We're looking at the volume of air that can be moved, we're looking at the flow rate of air, and we're looking to see how long that patient could blow out for. And all of this is demonstrated on the two graphs of spirometry, which is your flow volume graph and your volume time graph. So if you look at figure 1.2 in front of you that shows the flow volume and the volume time graph, this is a picture taken from a spirometry test conducted on a 12-year-old child. And if you look at the left-hand graph, the flow volume graph, the x-axis is showing that this child had a lung volume of round about 1.5 liters. The predicted volume was just over 2 liters. Can you see that on the x-axis of the flow volume graph? We can also see the volume of air that was measured in the volume time graph. So if you look at the y-axis of the graph on the right-hand side, and you take the end point of the test and look across at the y-axis, you can see again that this child blew out just more than 1.5 liters of air. So the FVC, the forced vital capacity in this child, is round about 1.5, 1.6 liters of air. Go back now to the flow volume graph. Look at the left-hand graph and the y-axis, and this axis is looking at a measurement of flow. So we can see that the fastest rate of airflow in this test, that is your peak expiratory flow rate, which is the peak point shown on this graph. This child blew out at about 4.2 liters per second. And then if we want to look at how long this patient blew out for, or this child blew out for, look at the x-axis on the volume time graph, and you can see there that this child blew out for almost 4 seconds, not quite 4 seconds. So just to reiterate, what you're seeing on these graphs here is the expiratory portion of the spirometry maneuver, starting at point 0 on each of the graphs and ending on the flow volume graph where the graph comes down onto the x-axis, and on the volume time graph where the line ends at just about 4 seconds. You can see that this child has measured slightly less than what is predicted. If you look at the little gray dotted lines, those show you the upper and lower levels of normal for this child. And you can see that the blow on both the flow volume and volume time graphs are round about just towards the lower side of normal, the lower level of normal. So we need to see the graphs on each of the blows so that we can assess each curve individually for an acceptable start, middle, and end of test. If we look at the numerical values in spirometry without assessing the quality of each blow, by looking at the flow volume and volume time graphs, we might miss errors such as cough or extra breaths or any artifact that would cause the results to be unsound. So it's really important that we look at these graphs to assess the accuracy first before we try to interpret what we see. And we also use these graphs to look at the shape of the curves against the predicted values and the lower level of normal as a first step in interpretation. And once we've looked at the graphs, then we can go on to looking at the numerical values to make an interpretation of the spirometry test result. So with spirometry, there's 4 factors that work together to produce accurate and meaningful test results. The first one is the operator. So the operator needs to be someone who is specifically trained and competent to work with children and who is familiar with pulmonary function testing in children. This person must be able to give detailed instructions, to encourage the child, not to be intimidating, and to give visual feedback after each maneuver to show the child what they're doing, what they need to do to improve the testing technique so that we get the very best test results. The spirometer itself needs to be accurate, so we need to look at the spirometer and do some calibration checks on the spirometer before we use it to ensure that it is in perfect working order. The child themselves needs to perform the test with maximal cooperation and effort. The environment also needs to be within recommended ranges for weather conditions, and it's important that there's a nice, friendly, clean, private, child-friendly environment for the child to be in when they are actually conducting the testing. That is also safe. And again, we'll look at this a little bit later. So those 4 factors work together to produce the best quality test results. That's a well-trained, motivated, and enthusiastic operator, a spirometer which meets all the technical requirements, a child that is well-motivated and cooperative, and lastly, an environment that is within the limits for ambient conditions and is child-friendly. So failure of any one of those 4 factors, for example, if the technician has poor coaching skills or is not very good with children, or the equipment is inaccurate, if the environment is outside of the recommended ranges for ambient conditions, or if the child does not perform maximal efforts, that is likely to produce spirometry results which could be suboptimal and lead to an inaccurate assessment of the spirometry test result and interpretation of that child's respiratory health. Let's look at a brief history of spirometry and the spirometer itself. So, whilst the measurement of lung function dates well back to the 16th century, at which stage the first measurements of lung function were when people tried to blow into, for example, a cow's bladder or a cow's stomach to see how large it could get. It was only really in around about the 1840s that the spirometer was originally invented, and that was done by a surgeon, an English surgeon, by the name of John Hutchinson. The device that he used at that stage was essentially a calibrated bucket that was placed upside down in water, and then the volume of air exhaled from fully inflated lungs could be accurately measured by exhaling into a tube leading into the bucket of water. And John Hutchinson at that time was the person who coined the phrase vital capacity, because he realized that the larger your vital capacity, the stronger you were, the more vital you were. And so that is a term that is stuck today, the vital capacity. How much air can you breathe from total inspiration to total expiration? And the larger that volume, the likelihood is the more vital you are, the healthier you are. Around about 1950, it was determined that 90% of respiratory disorders were obstructive in nature. So what that means is that there was a limited rate of airflow through the airways, whereas previously the vital capacity had only really measured restriction of the lung volume. So in 1950, Dr. Tiffenot of France introduced the forced measurement of air volume during a given time frame. So he was the person who brought in the forced expiratory volume in the first second, the FEV1, and the addition of this measurement gave us the ability to assess functional air flow and therefore limitation of air flow through the airways, which would indicate an obstructive impairment. So this is why the FEV1-FEC ratio is still sometimes referred to as the Tiffenot index, as it was Dr. Tiffenot of France who introduced the FEV1 and the measurement of the FEV1 against the FEC. So in terms of the significance of spirometry, today a spirometer is the most valuable respiratory diagnostic tool that we have available to look at respiratory health. So respiratory disorders are responsible for considerable morbidity and mortality in children. Spirometry is a very useful investigation for diagnosing and monitoring a variety of pediatric respiratory diseases. but it is currently underused by primary care physicians and pediatricians treating children with respiratory disease. We now have a better understanding of respiratory physiology in children, and newer computerized spirometry equipment is available with updated reference values for the pediatric age group. Although spirometry is a valuable tool, alone it does not provide an etiological diagnosis and should be taken in the context of the history and the clinical presentation of the individual assessed. So what we're saying here is that you never use a spirometry test on its own to make a diagnosis on a patient. It is used as one of the tools in a respiratory assessment to make a diagnosis. In terms of indications for spirometry, we're going to look at a table given to us in figure 1.5 and taken from the Standardization of Spirometry 2019 update, where you can see that there are 4 main indications for spirometry. The indications have been grouped under 4 different headings. So the first indication in everybody, adults and children, is to make a diagnosis. So it would be to evaluate the symptoms, signs, or abnormal laboratory test results, to measure the physiologic effect of disease or disorder, to screen individuals at risk of having pulmonary disease, to assess preoperative risk, and to assess prognosis. Under the second heading of monitoring, we would use spirometry to assess response to therapeutic interventions, so to medications that have been prescribed, to monitor the disease progression, to monitor patients for exacerbations of disease and recovery from exacerbations, to monitor people for adverse effects of exposure to injurious agents. This would be, for example, in the occupational health setting, and to watch for adverse reactions to drugs with known pulmonary toxicity. So what that means is that you don't necessarily only test people with possible respiratory disease or with respiratory disease. If patients are taking medications for other conditions, but those medications are known to be possibly toxic to the respiratory system, then you would test with spirometry to ensure that there is no damage taking place from the use of those medications. Under the third heading, disability impairment evaluations, spirometry is used to assess patients as part of either a rehabilitation program, or they're used for insurance evaluation, or they're used to assess people for legal purposes. For example, life insurance, things like that. And then lastly, other reasons for spirometry testing are for research and clinical trials, for epidemiological surveys, to derive reference equations, pre-employment and lung health monitoring for at-risk occupations, to assess health status before beginning at-risk physical activities. So for all people, whether it's adults or children, these are the indications for spirometry. These are some of the reasons that we would do spirometry under those 4 headings, being diagnosis, monitoring, disability impairment evaluations, and other. Then specifically for children, children are tested for the following reasons: to assess chronic cough and wheezing or persistent wheezing, to diagnose and monitor asthma and disease activity in cystic fibrosis, to review asthma control, and again, disease activity in cystic fibrosis, to monitor other diseases that affect lung function, and some of those diseases are hematological diseases or disorders, such as sickle cell anemia, thalassemia major, hemato-oncology conditions, connective tissue disorders, ataxia telangiectasia, and chest deformities. We would also use spirometry in children to ascertain preoperative lung function, which is what we've already mentioned in adults as well. And then sometimes school-going children are screened for respiratory disease so that we can pick up respiratory disease early and take the steps to prevent any problems. Contraindications to spirometry. Spirometry is generally a safe test, but there are a few reasons why we would not perform this spirometry test in children. And really, we would have to look at those conditions specifically. So let's just take a few quotes to put it into context for us. So performing spirometry can be physically demanding, The forced expiratory maneuver used in spirometry increases the intrathoracic, intra-abdominal, and intracranial pressures. So potential risks of spirometry are primarily related to maximal pressures generated in the thorax and their impact on abdominal and thoracic organs, venous return and systemic blood pressure, and expansion of the chest wall and the lung. The physical effort required can increase myocardial demand, so caution must be used for these patients with medical conditions that could be adversely affected by these physiological consequences. So although such risks are likely to be minimal for spirometry in most patients, the potential risks associated with testing should always be weighed against the benefit of obtaining that information from the spirometry test result. And spirometry must be discontinued if the patient has any pain during the maneuver. Spirometry also requires the active participation of the patient. So to obtain useful measurements, cooperation during spirometry testing is necessary. If the child has an altered mental state or is unable to understand directions or unwilling to follow the directions of the operator, the results may be suboptimal and not reliable for interpretation. In the pediatric setting, there are different challenges in terms of performing good quality and reliable tests. Young children have a smaller total lung volume and a larger airway size relative to older children and adults. This means that the forced expiration is completed in a far shorter time in very young children to older children and adults. The developmental stage of the child will also affect the ability of the child to perform quality testing, and an initial period of training is usually essential. Success is improved with a child-friendly approach, which may include the use of visual incentives and verbal encouragement, and with appropriate coaching, children as young as 2.5 years old with normal cognitive and neuromotor function are able to perform acceptable spirometry. So what we know is that whilst the results of other tests require no input from the patient, for example, an ECG or taking a blood test, the child really just has to sit there or lie there quietly to take those tests. With spirometry, it's different. We need a high degree of interaction and cooperation and understanding from a child to conduct a good spirometry test report. Getting results that accurately reflect the patient performing the test comes with understanding the essentials of spirometry. Poor patient performance yields poor test results, and poor test results can confound the process leading to the diagnosis and treatment. So the person interpreting the spirometry result does not always witness the test being done, and therefore relies heavily on the technician's skills for conducting and then reporting the test result in hand to come to an accurate conclusion and interpretation of that spirometry test result. So in spirometry, there is no substitute for a well-motivated and well-trained technician. And of course, the capability and reliability and accuracy of the spirometer itself must be understood. Spirometers that meet certain technical standards according to the guidelines should be used for testing. When it comes to limitations for spirometry, we know that the maneuver is highly dependent on child cooperation and effort, and is normally repeated at least 3 times to ensure repeatability. And repeatability means that every test that the child blows is basically more or less identical to the one before it. So we know that the child is blowing with the correct effort and technique every time they blow. All spirometry measurements are dependent on achieving the highest FVC maneuver possible. And additionally, spirometry should never be used, as I said before, as a standalone tool to diagnose respiratory disorders. We always use it as just one tool for making an interpretation on a patient. Due to the patient cooperation required, spirometry can only be used on children who can comprehend and follow the instructions given. Thus, this test is not suitable for any child who is too young, who may be confused or heavily sedated, or has any other limitations that would interfere with forceful blowing. Thinking about the complications and risks to spirometry in children, spirometry is generally a very safe procedure, and it rarely results in any complications for the patient. However, it can be physically demanding, and for this reason, occasionally can cause effects in some individuals, such as brief shortness of breath, dizziness, lightheadedness, coughing fits, bronchospasm, and occasionally looking at infection control. You could possibly pass infection on through a spirometer, although the risk of that is very, very small. Any effects that a child or a patient may have with a spirometry test is usually short-lived and resolved shortly after the test. So just to be very clear on the complications and risks for spirometry, again, we've divided this into 4 separate headings. You need to think about the increased intrathoracic pressure. If there is an increased pressure in the thorax, this leads to an increased pressure on the thoracic and abdominal organs. If you think there is a risk involved with this, with any condition that the child may have that is pre-existing, you need to think carefully about the effect of that increased intrathoracic and intra-abdominal pressure in that child. Spirometry will cause swings in blood pressure because it's physically demanding. So therefore, there's an increased demand on the heart. This can in turn affect venous and blood pressure. And therefore, you need to be cautious in subjects with medical conditions that can be adversely affected by these functional consequences. Expansion of the chest wall and lungs. So to perform a spirometry correctly, the subject must be capable of a full chest wall and lung expansion. And then active communicable diseases. Any subject with an active communicable disease, for example tuberculosis, poses a risk to staff and other subjects and should be delayed until we're quite clear that the risk of passing an infection on has passed over. All right, so personnel involved in testing, people who conduct spirometry testing in young children, have varied backgrounds and credentials. They can be people that range from physicians to nurses to allied health professionals to technicians. They must all have the ability to gain the trust of the child and to obtain measurements without causing distress to the child. So pediatric spirometry technicians should be able to identify any technically flawed maneuvers and to interpret the results knowing what each one of those problems may do to the overall interpretation of the test. Commonly used spirometers will generate printouts and reports regardless of whether the results are accurate. So it really is up to the technician and the person interpreting to look at the spirometry test result, to read the flow volume and volume time graphs, to look at any problems that have occurred, any artifacts that might be there that might lead to a serious misclassification of the individual's respiratory health. So simply reading a spirometer's interpretation printed out is totally insufficient. You need to be knowledgeable and you need to have a good understanding of the pitfalls that occur during the spirometry test itself, which can affect the overall test result and the interpretation of that test result. And this is essential for all personnel who are involved in pediatric spirometry testing. Just a little bit more information about the people. So generally, we've divided the type of personnel into 2 different groups. The first group is the physicians or the licensed healthcare professional. So this would be a doctor or a nurse or anyone licensed to oversee the pediatric spirometry testing program. And this person would supervise the spirometry technician. They would be responsible for the clinical interpretation of the spirometry screening test result. And they would ensure that the technicians have all the equipment they need to do their job, that the technicians are trained, that they're maintaining their levels of competency, and that they have all the resources they need to do the job. In some cases, this person might also be the one who's conducting the test. It just depends on the workplace itself, how big it is, how many people they have available for spirometry testing. The licensed healthcare professional will also evaluate the technical quality of the test result and the validity of the test result before an interpretation is made. They will interpret that test result in the context of the child's clinical presentation and manage that result accordingly They will know when to refer to other secondary or tertiary care institutions and when further care is warranted. That person, the licensed healthcare professional, is also the one who will communicate the meaning of the test result to the child or the child's caregiver or parent, and they will refer any child with persistent abnormal lung function despite appropriate treatment to a specialized pediatric service. Then there are the technicians. So these are the people who conduct the test itself. So spirometry technicians play a critical role in obtaining accurate and precise results. They often have the primary responsibility for maintaining the spirometer and checking its accuracy, preparing the children and coaching them to do the test correctly, and then to determine if the test is valid. So the technician must be motivated to effectively test each child. They've got to be fully engaged with the child. They've got to bond with the child, and they've got to have the ability to recognize testing errors and to be able to coach the child to do that test correctly. For pulmonary function testing in preschool subjects, it's essential that the operator has the ability to gain the trust of the child and that he or she is able to obtain measurements without causing any distress. So spirometry is not legislated, as far as we're aware, in any country in Africa. So there's no legal restrictions on who can perform spirometry testing. But I hope that we've been able to put the personnel into context for you for testing in your own workplace. Back to the limitations of spirometry. Because the maneuver is effort dependent, what that means is that it all depends on how the subject actually conducts the test itself. There's got to be cooperation and effort, and for this reason, the maneuver has to be repeated at least 3 times and up to about 8 times in each testing session, although for children, there's no upper level to the testing time. It's really on agreement with the child, and as long as the child is not getting exhausted. So spirometry can be used on children old enough to comprehend and follow instructions, and that's usually around the age of 5, but as I said, we can do it on children who are younger. The child has to be able to understand and follow instructions, so it's not suitable for anybody who is confused, heavily sedated, or has any limitations that would interfere with forceful blowing. And other types of lung function tests are available for infants and unconscious persons, but spirometry would not be useful for children with these problems. So to close off on this chapter, let's look at a few did you knows. So did you know that spirometry helps to classify functional abnormalities due to various diseases from restrictive, meaning that the lungs can't expand, and obstructive, meaning that the air flow through the airways is limited, but it does not determine the cause. So spirometry is not to be used as a standalone tool to diagnose respiratory disorders. The clinical usefulness of the spirometry test result is purely dependent on the quality of the test itself. Spirometry is fundamental to medicine as the blood pressure is when measuring somebody for hypertension, as the ophthalmoscope, as the ECG machine, as a chest x-ray, as taking a temperature, taking somebody's weight, all of those things. Spirometry is fundamental to respiratory health. And what we know is that only about 30 to 40% of primary care physicians, of both family practitioners and general internists, are actually using spirometry. So it's important that we start using it more often in practice. Thank you very much. That brings us to the end of chapter 1, and we will shortly be going on to chapter 2, respiratory anatomy and physiology.